Thank you, everybody, for joining us today. We are back with Lou Diorio, and we are going to be touching on a couple of different topics, but we're starting out with technology and how technology is going to affect the future of pharmacies. And I'm excited about this topic because not only is it important, and Lou has mentioned he's been seeing a lot of changes lately, but we are going to be talking about this at the conference as well. So this will be set us up. So if you have any questions, you can bring them to the event. Anyway, Lou, why don't you introduce us to the topic?
Hi, good afternoon, everybody. As the boss said, we're going to talk about automation, technology, and software, which I see as three different things. Immediately, when we talk software, everybody has some software available or in use. Technologies are sort of, to me, the tabletop lower cost entry into the world of automation and robotics. And then I'd like to talk a little bit about true automatic robotic practice. And the reason that I sort of pestered Vivian to put this together today is that we're seeing a direct trend from the post sort of COVID fallout of shortages, right? Everybody's talking about shortages. Supply chain is a problem, supply chain disruptions, supply chain shortages. I want to focus on two shortages in particular. Human resource shortages. Every one of our clients has reached out to us to talk about or whine about or complain about the inability to find competent and qualified technicians to help in the compounding process, as well as the inability to find competent and qualified pharmacists to help in the compounding process. So that's one facet of the shortage I want to talk about. The other piece is, no great surprise to anybody, the continuing and fluctuating drug shortages. So the shortage of raw materials, finished goods, all of that sort of plays into the conversation that I'd like to have this afternoon. I thought it was interesting, and with Vivian and I talked about this, I thought it was interesting that folks that 6 months or a year ago didn't have the money to invest in their compounding infrastructure to the tune of $10,000 are now reaching out to LDT and to me to help them vet devices that are in the neighborhood of $350, $450, $1 million. And that shift in the conversation, struck me as obviously very odd. And when you drill into why that's happening, a couple things. And the biggest one is that the shortage of labor and the fluctuation in labor is driving this, because you can be more efficient with the core staff that you have, and a call out or a cluster of COVID cases that puts a small amount of your staff on the shelf for that sequester time that everybody has in their protocols, or should have in their protocols per the CDC, that helps you sort of level out that labor model. So when we're talking about investing $350,000 in a syringe filler, or $650,000 in a oncology robot, those costs are more easily reachable if you put them in the context of, how does that help me flatten out and become more efficient with the labor I do have? And then all of the other safety and efficiency sort of tenets come with that, Vivian, right? Mm-hmm. Barcoding and particle counters and cameras and label capture and all the other elements inside their safety software that makes your production more traceable, more trackable, and in the event of a problem, much more easily recallable. So that's sort of that piece. And then if you make the assumption that the folks that are investing these significant dollars in this type of robotics, they do a full implementation, how does that play in the conversation about drug shortages, the shortages of API, the shortages of finished FDA approved goods that go into compounds. I would, I take the stance that if you can use the things that are already built into the basic robotic software, things like grouping like products together, things like, using overfill and using multiple vials more efficiently in these robots, that doesn't eliminate a drug shortage, because if you can't get it, you can't get it. But if you do have a limited supply of whatever drug we're talking about, it is probably a better bet that automation can help you maximize what you do have on hand, as opposed to leaving it up to individual humans who may or may not have the same sort of skills, the same sort of fastidious sort of thought process to make sure that you do maximize whatever raw materials you have on hand. So,
right. So the idea being that once it's automated and you've got the robots, you eliminate any risk of excessive waste.
Right. And if you go to my website, we talked extensively about controlling the process. So if you can standardize and control that process as it rolls along, and that's exactly what the robot and its software is designed to do, that forces the efficiency that we're talking about. So at the end of the day, you do get something for these really big outlays of money.
Right. And I think I mentioned, I talked to one company and they had something for IVs, automating the IV process. And they said, and I don't remember exactly how it worked, but it was something about how it not only automated the process or created more efficiencies, but it also, I guess, helped on time from running back and forth between the pharmacy. I guess you could have all the stuff right up there and then it would just automatically mix everything. Does that sound about right?
Yeah.
It was a while ago since I talked to them.
Yeah. I mean, if you dedicated 5 minutes to a compounding robotics and, you put that into Google, you'll come up with, thousands and thousands of hits. And I think, from a compounding perspective, you have companies like Grifols, like EquiShield, like Riva that are out there that are the new generation of automation. There are other companies that have been around a while, older technology, but now we've gotten to the point where companies like Grifols are developing. They're not purchasing automation; they are using their own engineers to develop true automation geared to pharmacy, because the first generation of robots, 10, 15 years ago, they were all repurposed from, robotic arms and things like that were repurposed from Detroit. So they were using a slightly modified assembly arm robot that would have been, putting rivets into a car and adapted it to the pharmacy practice. But now, because we are 2 and 3 generations removed from that, companies that have an engineering perspective or an engineering resource are doing things specifically for pharmacy. So for those folks out there that are looking at large production for whether you're an A or a B, if they're looking for repetitive formulations and high volume, right off the rack, you can get stuff for vial filling, syringe filling, flexi bag filling. If you have something that's a hybrid of that or something that's more specialized because of the competition, they're more apt to actually be able to create for you a custom solution. So that's kind of exciting. So there are things out there that can help you, and you just have to do your due diligence, get out there and talk to folks. And as I said, robotics, full-blown automated robotics can start at a couple 100,000 and go to, over 7 figures. So it's a big marketplace.
Let's talk then a little bit about the market that we're talking about, because I know that when we talk about this, a lot of times it's mostly about hospitals. But how does this tie into 503Bs and 503As?
Yeah, no, I think it's not exclusively hospitals. I mean, hospitals embrace syringe technology and repetitive fill technology because of the nature of their practice and because hospitals could control a formulary and they could sort of funnel doctors' prescription habits into a limited sort of song sheet. But 503As, because they are in a more competitive marketplace, had less ability to do that. But because of FDA activity and the requirements for end product testing and sterility testing and the expenditures that are required to put together a valid beyond use date to put on your prep, the marketplace has, as far as the breadth of SKUs, the number of items that are being produced, that's actually coming down. So it's actually 503A practice, community practice, independent compounding has actually come to sort of meet that. So if you do have a practice where you have several, repetitive fixed formulations that you are spending an incredible amount of labor to produce, well, then why not automate that process? For 503Bs, and this goes back to the early 90s when robotics started to rise and really get up to sort of a viable commercial point. Companies like CAPS, companies like Pharmedium investigated robotics, and Pharmedium in particular was looking at automation back then because both of those providers, their compounding model is and was very well. Pharmedium's gone, but the model was very hands-on, literally, and labor intensive. And the reason that they didn't jump in the boat for automation was the lack of throughput. So relative numbers, I mean, we have production pharmacies that are manually creating with a single technician, for round numbers, 50 to 60 IV bags an hour with relative ease and with a high level, because of barcoding and because of some other in-process checks, with a high level of confidence. You look at some of these automated, robots, and after you plop down $1 million, their top throughput is somewhere between 15 and 20 bags an hour. Mm-hmm. So, it's economies of scale. Now that seems to be shifting. There are robots out there that if you do a single fixed formulation over and over and over again, they can get you to, on the syringe side, 150 units an hour. And on the IV bag side, 100 plus, depending on exactly what the preparation is. So it's more reachable. So 503Bs are, depending on what their business is, there are obviously, I've been to 503Bs that are already using robotics because the great bulk of their menu, if you will, are syringes, and syringe fillers have been around for a long time, and so have vial filling equipment. It's just a matter of, in the past, you would go and you would buy what was traditionally considered a full-blown CGMP vial filling line. So that would come with a huge price tag. That would come with a lot of burden of upkeep and setup and a certain expectation of engineering expertise that you had to have on site to tweak these lines. I mean, we had a client several years ago that was moving towards 503B. They were using a Cazzoli vial filling machine that at full production could fill and cap 30,000 vials an hour. Their batch size was 2,000, 3,000, 4,000. So they would spend the entire morning setting this thing up, run it for half an hour, and then spend the rest of the day cleaning and breaking it down. So that kind of labor, that kind of labor math really didn't make too much sense. But now with the new technologies getting smaller, getting more user friendly, it's more reachable,
Right.
and go ahead.
Okay. Well, my question is, so that's really good information. But what I was wondering, my next question is, you said that all these clients now are calling you and asking you, what are the questions that they have? What is it they're asking you to look into? Is it just that to look into the specifics, or how you can, the specifics of what will work for them? Or is it also things like how can they better streamline their entire process? And then you kind of left up to figuring that
Yeah,
out.
the assumption is that any automation, and it's probably not correct, but the assumption.
And sorry to interrupt. There's one more
question.
There is another part of that question, which is, good Lord, now I forgot what it sorry, I didn't mean to interrupt.
Again. Good.
No, it went out of my head.
The jumping off point is that any automation is going to make you more efficient and increase your throughput. That's only true to a point. If you have to totally scrap your labor model, you have to totally scrap your operational and production model, you only do that if you really are getting a significant change, a significant uptick in your process. So some of the more small scale folks, it's a matter of, the old technology was, you buy our robot, you have to do it our way. Well, with software being where it is now and the flexibility of some of these robots, they can actually push it into your current process and make that process more efficient. It's not as it was in the old days, where it was a matter of throwing out the baby and the bathwater and having to learn the robot, right? This is the old, for those of you that were, Twilight Zone fans, right? Is machine serving man, or is man serving machine? And, my sort of experience is probably the best solution for you, and there's no one solution, but probably the best solution for you is somewhere in the middle. Right. So that's one consideration. The other bit of vetting beyond price is the ability to finance, right? Which is, monetary. Space, right? Do you want to bring in a robot that's going to require huge renovation in your physical plant? In the past, I would almost bet 90% of the time that if you brought in automation, you had to expand your footprint. Mm-hmm. That's not true anymore. Those technologies that I mentioned at the top that are tabletop, in addition to some of the newer robots, they can basically fit into the same footprint that you have a 6-foot laminar flow workbench or a 6-foot biological safety cabinet. So it's a matter of, now you have the real estate, it's a swap out. The other bit of this is, can you get the right disposables? Are the supplies available for these robots? That's why there's a lot of question. This question comes up a lot more when you're talking about hazardous drug. Mm-hmm. There's a hazardous drug robot out there that uses their own proprietary spikes and tubing. And, that to me is kind of a foolish, you're putting yourself into a corner by design. And if we're talking about single source and supply shortages, why would you want to do that to yourself? So that's a concern. The other bit of this is, the software. How difficult is it to learn the software? How much support am I going to get from the vendor? How much customization of the software or integration of the software into my pharmacy or into my hospital's HIS system, right? Even for those guys and ladies out there that are doing long-term care compounding, and can you, have you just created an informational island, and you're going to have to do a whole bunch of data entry to get it into the into the medication record. So a lot of that gets flushed out before any contracts are signed. What does it take to clean these things? How much is it going to cost for me to validate the products, the preps that are made on these robots? It's not part of current 797, but is certainly in the proposed 2021 out for draft chapter, that the validation of these robots is going to be less sort of fluid and more rigid in its requirements. So that comes with an associated cost. So we are more than capable of doing a match between the pharmacy and the reference laboratory that's going to do that testing. Can that testing, if that testing is not done correctly and questions get asked by an accrediting body like the Joint Commission or ACHC, the local board of pharmacy or the FDA, and you don't have robust enough data, that whole program goes offline until you can provide those documents to whatever regulator is asking. So those are all the complex things that we go through when we talk about vetting and setting up an implementation plan for the particular pharmacy or compounding business that we're talking about.
Okay, great.
Big or small.
Yeah. All right, good. We have to end it there because we're past our 15 minutes. But I guess the beauty of this conversation is if you want to know more, you can come to the conference.
There you go.